Today, I would like to thank the organizing committee for the invitation to talk to you about the approach to the management of COVID-19 and diabetes. These are my disclosures. And for this session, our objectives are to discuss the importance of the hyperglycemia in patients with diabetes and COVID-19 infection. Also try to establish the mechanisms causing poor outcomes in patients with diabetes. We also discuss anti-diabetic medications in patients with COVID-19 and consider data on vaccines for patients with diabetes. We all know that the spread of COVID-19 has reached pandemic proportion and represents a threat of increased morbidity and mortality among these three patient population: diabetes, hypertension, and obesity. And in an analysis in Mexico of some of the patients that were admitted and died because of COVID-19, we've noted that the attributable fraction for diabetes and hypertension and obesity for those who were hospitalized and treated in the outpatient division was significantly high, especially among those with diabetes, hypertension, and obesity. Again, these three chronic conditions has showed increased case fatality rate, even higher than those patients with chronic kidney disease as well as COPD. So it's very important for our discussion at this session to discuss the effects of hyperglycemia and how hyperglycemia presents in patients with COVID-19. So as you can see, hyperglycemia may be seen at admission. So it may present as what we call stress-induced hyperglycemia. Hyperglycemia, of course, may be noted in those type 2 diabetic patients who are uncontrolled, and there's a new entity called new onset diabetes because of COVID-19 infection. And these three presentations of hyperglycemia with COVID-19 infection has shown worse outcomes in these three presentations. So this is a study looking at all-cause mortality according to admission blood glucose groups, and this is from the Spanish semi-COVID-19 registry. So this looked at more than 10,000 patients admitted for COVID-19 infection. So if you look at the hospital death or mortality in these patients based on blood glucose levels, if you look at the graph showing the dark blue bar, so these are the total number of patients. In red are those patients with diabetes, and in light blue are the non-diabetic patients. So as you can see, hospital death increases with increasing blood glucose levels. Particularly notable, of course, are those patients who are diabetic in red. But I think we have to really look likewise at those patients with higher mortality, even if they are non-diabetic, as represented by the light blue bar. So this study showed that regardless of diabetes status, blood glucose levels of more than 180 milligrams at admission showed increased mortality or hospital death. In another study wherein they looked likewise at mortality rates, if you look at this table on the left, looking at diabetic patients and as well as those non-diabetic but with uncontrolled hyperglycemia versus those patients who are non-diabetic and with controlled blood sugar, you see an excess in mortality rates. But if you look, on the other hand, on patients with diabetes with HbA1c of more than 6.5%, which are uncontrolled, versus those patients who are not known diabetic but with hyperglycemia presenting in the hospital, it showed that mortality rate was actually higher in this non-diagnosed diabetic but hyperglycemic, or those not known diabetic. So that shows you that really hyperglycemia confers increased mortality rates, even for those non-diabetic patients. This is another study looking at fasting blood glucose at admission, representing an independent predictor for 28-day mortality, even for those patients without previous diagnosis of diabetes. So again, these are non-diabetic patients with admission blood sugars of between 6.1. They were stratified into two groups, 6.1 millimoles, 6.1 to 6.9 millimoles, and those with elevated fasting blood glucose of more than 7 millimoles. And as you can see, for the cumulative mortality, with higher fasting blood sugar at admission, you see higher mortality rates. Similarly, the survival curves for patients with worse CRB65, which is a measure of clinical measure of pneumonia severity. So the higher the point, the more severe the condition is. It goes without saying that if your CRB65 is within 3 to 4 points, so you see that the mortality is higher. So there's nothing unusual about that. When they looked at survival rates of COVID-19 patients with CRB of 0, as stratified by fasting blood sugar, again, so these are non-diabetic patients, but if your blood sugar is high, even with your CRB at 0, you will see that cumulative mortality is higher. But more than that, no, if you have hyperglycemia of more than 7, and if CRB is more than 0, you will see that the mortality, cumulative mortality, is increased, okay? More if you have those two combinations together. So that again shows you that hyperglycemia, even for unknown diabetics, is a very important predictor of 28-day mortality. So this is a study looking at dynamics of laboratory parameters between non-diabetic as well as type 2 diabetics. As you can see in this study, diabetic patients compared to non-diabetics. So diabetics in black versus those patients who are non-diabetic in red showed significant differences in their presentation. As you can see, diabetics have lower oxygen saturation at presentation with highly sensitive cardiac troponin, with higher CRP levels, increased creatinine, increased granulocyte count, lower lymphocytes, and with concomitant cardiovascular and coronary heart disease. What is also important in this analysis was when they looked at all diabetic patients with poor as well as well-controlled blood sugar level. When they look at the characteristic likewise and they compare mortality, as you can see in the graph on the right, if you look at survival rate for patients with diabetes versus non-diabetics, you will see that survival rate is considerably lower among diabetics compared to non-diabetics. But more so, when you look at survival curves of patients who are poorly controlled versus well-controlled diabetic, you will see that the survival curves for well-controlled diabetic is a lot better than those who are poorly controlled. So this cohort of 7,000 COVID-19 patients without diabetes, with and without diabetes, showed increased need for medical interventions for those patients with diabetes. Also, it showed increased mortality for diabetic patients and well-controlled blood glucose correlated with improved outcomes in infected patients. So this visual abstract shows the very important difference. Survival of 98.9 for those patients with well-controlled diabetes versus death of 11.0% for those with poorly controlled blood sugar. So aside from those two conditions, acute hyperglycemia, those with uncontrolled diabetes, there's also a third entity in patients with COVID-19, and that is the presence of what we call new onset diabetes in COVID-19 infection. So there is the COVID-Diab project. This is basically an international registry wherein they try to identify those patients with new onset diabetes. So these patients basically have no history of diabetes. They came in with normal HbA1c, but eventually had severe hyperglycemia in the hospital and persistent to be hyperglycemic after discharge. So the COVID-Diab project, so again, is an international study looking, the global registry of COVID-19 related diabetes mellitus. So that if you look at SARS-CoV-2 effects, you will see that it may cause beta cell damage and, as we all know, cytokine storm. So these two conditions can present as admission hyperglycemia. It can also present as worsening metabolic control in patients with diabetes, and as I've mentioned, new onset diabetes mellitus. And this will eventually translate this manifest in patients, especially with obesity, those with other inflammatory conditions, problem with coagulation. They may present with acute metabolic compensation. If they're older, if they are hypertensive, if they have renal disease, all of this, no, manifestations of hyperglycemia will lead to what we call poorer outcomes. And why do we have poorer outcomes? So because of the increased susceptibility primarily of the pancreas. So this is a big figure looking at endocrine organs that can be affected by COVID-19. So for us endocrinologists, we should be aware of the thyroid, the adrenal gland, the pituitary gland, the reproductive system, even the bones and the fat cells may be affected by COVID-19 because of the presence of the ACE2 receptors. And that holds true even for the pancreas. So just a short review, though we are well familiar with the COVID-19, with the virus, which is a coronavirus with the very peculiar spike proteins. As we all know, entry to the tissues or entry to the host is by a binding of the spike proteins to the ACE2 receptors. This binding of the ACE2 receptors to the ACE2 receptors may be facilitated by other factors, like for example, your TMP, RSS2, or your transmembrane serine protease that will also catalytically help binding of the spike proteins to the ACE2. Another is your furin that is upregulated in patients with diabetes mellitus. They will also facilitate viral entry and eventual replication. So in patients with diabetes, there are specific abnormalities or cellular molecular components that could contribute to increased susceptibility to the infection. Okay, so as I've mentioned, there's upregulation of ACE2 in patients with diabetes. There's also upregulation of furin, which enhances viral invasion. You have your TMPRSS2 or your transmembrane serine proteases, which enhances fusion of viral and cellular membranes. You have your ADAM17, which are metalloproteinases, which promotes uptake of the SARS-CoV-2 virus into the cells, which is also upregulated in diabetic patients. You have your GRP78 or your glucose receptor related proteins, which provides binding to the SARS-2 spike proteins, and your IFT-M3 or your interferon membranes, or which enhances and shuttles the virus particles to the lysosome. So these conditions actually facilitate entry and infectivity of COVID-19 among patients with diabetes. And this translates to clinical manifestations. Now, basically, mechanisms, as we saw earlier, there is that upregulation of ACE2 among patients with diabetes. We all know that there is dysregulated immune response in diabetic patients, especially those with uncontrolled diabetes. There is a concomitant alveolar restriction, as well as a problem with regards to oxygenation that is inherent among diabetics that may be due to anatomical changes. Thus, they are more prone to develop hypoxemia and eventual need for mechanical ventilation. And of course, diabetes is characterized by endothelial dysfunction and even risk for coagulopathy. And these are manifestations that we see with patients with COVID-19 infection. So that the consensus recommendation for COVID-19 and metabolic disorder for both outpatient and inpatient care is really prevention of infection for COVID-19 in patients with diabetes. If they are infected, make sure that they are properly managed, they are properly monitored in the inpatient or even in the intensive care. Therapeutic aims are to maintain plasma glucose of between 72 to 144 milligrams per deciliter, and as much as possible control HbA1c, do more frequent monitoring using a continuous glucose monitoring or flash glucose monitoring, and again control blood sugar as tightly and safely as possible. Okay, we'll now go to specifics on drugs, okay, for diabetes mellitus. So these were recommendations with regards to therapy or the available oral as well as injectable therapies in patients with diabetes. Of course, we all know that there are advantages and disadvantages for each of these medications. So good for metformin is that there's no risk for hypoglycemia, although there is less risk for lactic acidosis, respiratory distress, and those patients with renal impairment as well as heart failure. For DPP-4 inhibitor, there were no risk for hypoglycemia. They can be used for those patients with wide renal function. Those may have renal insufficiency. It has potential anti-inflammatory action and may potentially modify SARS-CoV-2 binding. And I'll show you some of the mechanisms later. So there's no known disadvantages. SGLT2 again has no risk for hypoglycemia, but there is risk for hypoglycemia as well as electrolyte imbalances and even euglycemic ketoacidosis. Sulfonylurea may increase your risk for hypoglycemia, especially for those patients with infection and poor oral intake. Pioglitazone may have anti-inflammatory action. However, there's increased risk for fluid retention and heart failure. GLP-1 receptor agonists, which are injectable, have potential anti-inflammatory action, though they may have gastrointestinal side effects and risk for aspiration. And of course, insulins are recommended for critically ill patients, though the risk for hypoglycemia is very high. But you also have to consider that these medications may also have interactions, okay, with medications that may be given for the viral infection. So this is a retrospective analysis looking at the clinical characteristic and outcomes in patients with diabetes and COVID-19 in association with their glucose-lowering medications. So these are patients with COVID-19 that were admitted. As you can see, these are 904 patients, 136 of which were diabetic, and they compared oral anti-diabetic agents. Also, they looked at RAS blocker use, looking at in-hospital death and poor prognosis as outcomes. So with specific interest to anti-diabetic medications, you will see that use of metformin, insulin, alpha-glucosidase inhibitors, secretagogues, and DPP-4, when you look at the hazards risk for associated inpatient hospitalization and poorer prognosis and even death, you will see that the medications are not associated with the outcomes in hospital death and poor prognosis, except for if you look at the point estimate as well as the hazards ratio, except for insulin. And they noted that most likely the in-hospital death and poor prognosis is primarily because of the more severe hyperglycemia, because they needed insulin at the onset. How about metformin? So the effect of metformin consumption in mortality in hospitalized patients. This is a meta-analysis of several trials showed that it may be protective, okay, with regards to the outcome of hospital mortality, among patients that were COVID-19 positive taking metformin prior to admission. And this was likewise tackled in the Coronado study, the coronavirus diabetes outcomes. So they pulled several data from several sites in France. So they enrolled more than 2,000 patients hospitalized for COVID-19, and they looked at outcomes, primarily hospital discharge, and look at particular factors that contributed to those outcomes. So as you can see, for hospital discharge, as you can see on the box on the left, so basically those in blue are those positively associated or good factors. So routine metformin use, longer time between symptom onset and admission were factors of hospital discharge, while higher age, history of microvascular complications, routine anticoagulation therapy, dyspnea on admission, and elevated AST, elevated white cell count, and CRP was not associated with hospital discharge. The other outcome, which is death, okay? So those that are positively correlated, or meaning protective or safe, now with regards to death, again, the same two factors, those who are which were associated with this outcome are higher, quite the same, no, except for the addition of platelet. So reduced platelets. So this is the forest plot of all of those analysis. So again, favors discharge as well as favors survival are those patients metformin with short onset of symptoms, okay, at admission. So they were likewise protected. If you look at those, if you look at other than metformin, if you look at insulin, so it barely, if you look at the hazards ratio, it's 1.01 to 2.06. So again, similar to the initial study on glucose therapy, so use of insulin favors poorer outcomes. So again, probably these patients are very sick in the first place. So other than that, okay, your older age, the more microvascular complications, more dyspnea, elevated ALTs, elevated white cell count, and elevated CRP as associated with no discharge as well as mortality. How about DPP-4 inhibitors? So these are different studies showing different outcomes, okay, or effects, with DPP-4 inhibitors. So there are studies showing no harm nor benefit. There are studies showing harm for DPP-4 inhibitors, and there are studies showing benefit for DPP-4 inhibitors. So this is one particular study showing published in the Diabetes Care, showing sitagliptin treatment at the time of hospitalization was associated with reduced mortality. So this is a multi-center case-controlled retrospective observational studies whereby 338 type 2 diabetic patients with COVID-19 were compared open label between those patients who were given standard care versus sitagliptin, looking at discharge from hospitalization in death and improvement of clinical outcomes as measurable endpoints. So as you can see in the Kaplan-Meier curve on the right, so if you look at the patients, percent of patients free from the event, okay, you will see overall uh, the separation of the lines favoring sitagliptin versus standard of care. So with regards to outcome. And other than that, when they did a subgroup analysis exploring the effect, subgroup analysis by age, it was very consistent that better outcomes was seen in those patients given sitagliptin, regardless of gender, regardless of age, as well as baseline BMI. Okay, so that even for those patients with baseline HbA1c of 7.5, sitagliptin was shown to be beneficial with regards to the outcome measures. And some of the hypothetical mechanism for how DPP-4 inhibition may influence COVID-19 is that one, though we all know that SARS-CoV-2 virus binds to ACE2, the MERS-CoV-2 virus primarily binds to DPP-4. This is the Middle Eastern respiratory virus before, no, in the early part of 2020, 2010, you will see that there is now some data that they could be co-binding of your SARS-CoV-2 to your ACE2 as well as your DPP-4. Okay, so that is why when you give a DPP-4 inhibitor, if you look at the panel on the right, okay, as you can see, your SARS-CoV-2 virus is likewise binding not just, okay, to the ACE2 but also to the DPP-4 enzyme. So the DPP-4 are located in the target cell. Okay, as you can see here in the endothelium, for example, there are what we call membrane-bound DPP-4 as well as soluble DPP-4. So that when you give, for example, a DPP-4 inhibitor, what happens is that you will be blocking the binding of the SARS-CoV-2 or COVID-19 to the DPP-4 binding site. But aside from that, patients that are given DPP-4 inhibitors also have high levels of soluble DPP-4, okay? So that they will act as somewhat as what we call uh, receptors, okay, decoy receptors, okay, binding the SARS-CoV-2. So that is why, hypothetically, it is said that DPP-4 inhibition may actually be protective or safe among patients with COVID-19. So there is also a study that is that has been started, okay, and this is the DAPA-DARE study. This is looking at the effects of dapagliflozin on prevention of major clinical and recovery in patients with respiratory failure because of COVID-19. So this is called the DAPA-DARE study. So they're trying to enroll adult patients hospitalized with confirmed COVID-19, randomized into usual care, and dapagliflozin. Okay, and they were assessed based on the composites of death from any cause or new or worsened organ dysfunction and down the line. All-cause mortality, new or worsened organ dysfunction. Okay, and eventually respiratory decompensation, cardiac decompensation, or doubling of serum creatinine. So this is the DAPA-DARE study. This is still ongoing, and the rationale for this, because as we all know, part of the recommendation is that you actually stop SGLT2 inhibitors, no, in patients who are acutely ill, mainly because of the risk for euglycemic DKA. However, they are postulating that because of the very good cardiovascular outcome trials for SGLT2 inhibitors, specifically with dapagliflozin, those effects are actually protective, and those effects probably address common mechanisms in patients with COVID-19. As you can see, SGLT2 inhibitor will increase endothelial function. It will reduce oxidative stress, inflammation, and insulin resistance, so that they may be very beneficial among patients with these conditions. Okay, and this said effects of SGLT2 inhibitor will likewise target or address the effects of COVID-19 infection. So this is the common mechanisms that is hypothesized to be improved with SGLT2 inhibition among patients with diabetes and COVID-19 infection. But aside from those trials, I've mentioned the DAPA-DARE trial for SGLT2 inhibitor. There are other trials, the MET-COVID trial for metformin. Again, these are ongoing trials. The CDIACO, the effect of sitagliptin in treatment for COVID-19 diabetic patients. So this study is actually born out of the retrospective study that I mentioned earlier. There are also studies for linagliptin. This is effects of DPP4 on COVID-19 and efficacy in patients, in patients, okay, those admitted in the hospital. So these are linagliptin studies, and we'll be waiting for this randomized prospective trials. So what are concerns on critical care? So concerns on critical care, so you can access the UPPGH consensus recommendation for inpatient management of diabetes among persons with COVID-19. There's also an endocrine society publication on initiating insulin in acute setting. This is what basically the recommendations are the same as to what we do for any infection. Okay, it's just that we've noted higher higher total insulin requirement for those with COVID-19 infection. So basically make use of basal insulin, prandial insulin, and corrective insulin. So the use of those agents will be dependent if the patients are eating on NPO, on parenteral nutrition, on bolus feeding, or on enteral feeding, etc. So these are the insulin therapies in acute care setting. However, there are now recommendations or the pros and cons of several insulin regimens in the ICU or even in the ward for those patients with diabetes and COVID-19. Very important that we consider contact frequency per day, no? If we will assign insulin therapies. So aside from contact frequency per day, glycemic control, glycemic variability. So this is important because if you, for example, use insulin infusion, so glycemic control is very best. No, it's best. Glycemic variability is low, okay, because you can titrate readily with an infusion. However, contact frequency is high, okay? So that you have to balance, okay, the need for control as well as exposure of the healthcare professional. So for example, basal insulin Q12 or regular insulin Q6 for correction. So you can see contact frequency is lower. NPH every 8 hours or regular insulin every 8 hours, fewer contact, although there is greater variability as well as greater poorer glycemic control. But this just shows you the things that you have to consider when you assign insulin therapy. Risk of hypoglycemia upon continuous feeding interruption is also considered in this table, as well as what to do, how to mitigate, okay, those episodes of hypoglycemia in this different insulin algorithm. So in the critical care, of course, we also have to be aware of the use of dexamethasone among patients with diabetes. So this is the recovery study. So this is a study particularly done among hospitalized patients with COVID-19. So not diabetic. So just with COVID-19, because we all know that diabetics may also benefit from dexamethasone, because in the recovery study, again comparing usual care versus dexamethasone at 6 milligrams once a day for 10 days, looking at particularly 28-day mortality. So if you look at all participants, so different for different patient group requiring oxygenation. So meron tatlong group. So those who needing invasive mechanical ventilation, oxygen only, or no oxygen received. If you look at this Kaplan-Meier curve, for all participants, that showed benefit of dexamethasone at 6 milligrams OD. But the benefit was primarily seen only for those needing invasive mechanical ventilation here, as well as oxygen therapy, and there was no benefit for those patients not needing oxygen. Okay, so that's dexamethasone, 6 milligrams once a day for 10 days. In the meta-analysis, again, looking at the effect of corticosteroids using 28-day all-cause mortality as an outcome. As you can see, the eventual point estimate was significant, okay? Overall, okay, with the use of steroids, so be it dexamethasone, hydrocortisone, methylprednisolone in this meta-analysis. So how about vaccines in diabetes? So this is a publication looking at different vaccines available currently. So you have there the Pfizer vaccine, Moderna, Oxford, Gamaleya. So they just look at those different studies and if ever diabetics were enrolled in these studies. Okay. So the PSEDM, that's the Philippine Society of Endocrinology, Diabetes and Metabolism, came up with a document on vaccinations among patients with diabetes. They noted, they just actually cited data on the different trials. For example, Pfizer BioNTech, they noted the clinical trial included 3,150 people with diabetes, or 8.4% of the trial population, with the phase 2 and 3 trials of the Astra Oxford vaccine. They noted 2.3% of the total population in the trial were diabetics. In the Sinovac FDA review, they noted that not recommended to adults with comorbidities, as the Philippine FDA EUA indicates use for clinically healthy adults only. Okay, so in summary, hopefully I was able to show you that hyperglycemia is an important predictor of poor outcomes in patients with COVID-19, be it due to stress hyperglycemia, poor diabetes control, or new onset diabetes. More so for for acute hyperglycemia. Physiologic changes in diabetics confer increased susceptibility to poor outcomes and even death, which is mostly driven by dysregulated immune response and endothelial dysfunction. Anti-diabetic medications are generally safe in COVID-19 infection and may be potentially beneficial at best, like metformin and DPP-4 inhibitors. And data on vaccines used among diabetics are available in some of the vaccine trials. Thank you very much. So in summary, hopefully I was able to show you that hyperglycemia is an important predictor of poor outcomes in patients with COVID-19, be it due to stress hyperglycemia or new onset hyperglycemia, poor diabetes control, or new onset diabetes mellitus. Physiologic changes in diabetics confer increased susceptibility to poor outcomes and even death, which is mostly driven by dysregulated immune response and endothelial dysfunction. We've also shown you that anti-diabetic medications are generally safe in COVID-19 and may be potentially beneficial at best, like your metformin and your DPP-4 inhibitors. And data on vaccine use among diabetics are available in some of the vaccine trials. So with that, thank you very much.